Corby Community Hospital, and we are physical rehab units. We're part of unplanned care in the Trust, and in the wider health economy we're part of the urgent care pathway. That means we get put together with KGH and NGH, so all that angst about 4-hour A&E targets, patient flow, delayed transfer of care is also our pain. So we are a challenged health economy in terms of patient flow and in terms of delayed transfers of care. This means that if you come to the attention of NHS England, lots of helpful teams come and visit you to help you get better. So in autumn of 2015 we had the emergency care intensive support team come to the county. They asked us as community hospitals to implement a safer patient flow bundle and red to green. Not been done in community hospitals before, it was new to the acutes, nobody in community hospitals has done it. And they asked us to start on the first week of December, which in our world is winter and possibly the third worst week for winter pressures that there is in the whole year. We'd have done anything else but start a new project that week. We'd have done anything, but no, we had to do it. So Red Day is a day when nothing positive happens to improve a patient's rehabilitation potential or to progress them towards their discharge. A green day is obviously the opposite, something positive happens and they're getting nearer discharge or their rehab potential is improving.
We had to do an audit on ourselves and we were asked various questions, and all the questions are on that sheet there. The green ones were the bits we're doing already, and the amber bits are where we had to look at our practice. The first thing was looking at EDDs. What's an EDD, guys? Come on, guys, what's bit now, Donna. So we had to make sure every patient had an accurate EDD. So we started working much more closely with our therapy staff and medics to make sure that EDD was relevant to that patient and achievable. We were also supposed to be reviewing every patient 7 days a week from a senior point of view. We only normally work with band 5s at the weekends with our nursing staff. Our medics don't work weekends, nor do our therapists. So that soon went to a 5-day-a-week review. Each patient was also supposed to be seen by a medic 7 days a week. Again, remember it's a very acute focus tool we were trying to implement. Again, that soon went to 5 days a week, that review. We were also asked to look at our admission criteria, making sure we're getting the right patients into our beds. And that's ongoing work. Rose's done a lot of work with that over the last so many years. And that's an ongoing process. We're still getting the wrong patients in our beds at times. And that's going to continue to happen, I think. But as long as we work out on the admission criteria, it should get better. And then we sort of implemented it into our therapy teams.
I'm Corinne, I'm the physio that works at Corby. One of the criteria that we had to meet was that the patient and their family were fully aware of what's happening today, what's happening tomorrow, and what needs to happen for me to go home. Initially we had laminated sheets with these questions on each of the patient's tables. So that the patients could see exactly where they were in their journey. But we found this didn't work for our client group. In some cases, it wasn't appropriate to answer that final question until we'd had meetings with the family and decided on discharge destination. And also some of our patients had cognitive issues and they found it distressing to be reminded of the answers to those questions on a daily basis. The CCG weren't sure how well we were meeting this criteria, so they made an unannounced visit in March 2016. But they found that as a result of our patient-centred goals and also of our involvement of families in the family meetings, that our communications were exemplary.
We devised a coordinators book, so during handovers and MDTs we could assign tasks to specific professionals. This got us into the mindset of task-orientated discharge.
We found that doing a board round every day was just impractical due to time constraints, so we quickly reduced that. We also found that it was impossible to complete the spreadsheet for the day that morning, because obviously you intend to see someone when it's a green day, but then for whatever reason you don't get to them, it turns into a red day. So we started filling it in the next morning retrospectively for the previous day.
So we discovered that not all patients fitted into just red or green, so we developed amber, which meant that patients were still receiving rehab, but it could be continued elsewhere with other services. We also documented when patients were fit for discharge, as at that point they went from being green to being amber. And we also documented if patients were not clinically stable.
So basically what we did is we took a tool that we were told we had to use that wasn't designed for our setting. So we chucked out the bits that we didn't like, that didn't work for us, to great consternation higher up the trust in some points. We took the bits that did work for us and ran with those, and then we invented a few bits that worked for us even better to make a tool that was applicable to us. And then we rolled it out to the other community hospitals the following summer.
And we won the award as well.